Well, I am going to be talking about maternal nutrition during pregnancy, and I have 20 minutes to do that. And you know, pregnancy is a 40-week, 9-month thing, so we're going to compress 9 months into 20 minutes. This is also going to be a audience participation portion of the program. So I'm going to ask you a question and think about a pregnancy, and what would you describe, what sort of things, what sorts of aspects of a pregnancy would be something you would consider when you're thinking about a successful pregnancy? If you're thinking about a successful pregnancy, what's included in that? And think about who's involved in that pregnancy. Yeah. Healthy, okay, the embryo fetus gets through that pregnancy and they are born live and healthy. So that's one, is the baby's born and it's a live birth. Healthy mother, so that's the second person. And there's one other aspect of this that may not be initially obvious, but if that baby's born, how do you know they're going to be viable? What sort of period of time do we usually think about? And I may need to give you a little bit of a hint here, but infancy is the first 12 months of life. If that baby's born and they have what they need to survive out in the real world, and I call this the transition from the womb to the world. If that child has what they need, that infant has what they need to make that transition and able to survive that first year of life, that period of infancy, that's another measure of successful pregnancy. So the mother survives the pregnancy, the baby's born and is healthy, and that baby is able to survive that first year of life. Now, there are statistics kept on those three things. The stillbirth ratio or fetal death ratio is not really a very good statistic because it's just hard to gather all that information, especially the first 20 weeks of pregnancy. There's not a lot of good statistics out there, and you can probably imagine why. You know, the mother may not know she's pregnant, or if she is pregnant and she loses the pregnancy, she doesn't report it. It just goes unreported. The last 20 weeks of pregnancy, there's better statistics there. Healthy mother, maternal mortality rate is pretty well kept, and there's pretty good statistics worldwide in that, or at least in developed nations. And then infancy mortality rates is also very well kept. Now, in the United States, and this is old statistics now, but about 6.4 stillbirths per 1,000 live births is a statistic the last 20 weeks of pregnancy. And usually these ratios are given per something, per 1,000 live births, or per, in the maternal mortalities over 100 pregnancies. I couldn't find information about more about Romania. You may have that information. Early in pregnancy, we really don't have very good information in any country. But maternal mortality, we do have pretty good information. And this is 2008 statistics, 24 mothers per 100,000 live births. And this definition is live births is during pregnancy. That mother, if they're one of those 24, that mother could perish during the pregnancy, or in the process of childbirth during labor and delivery, or within that first 42 days after birth. If there's some sort of complications that happen related to that pregnancy and the childbirth, that person, that 24 out of 100,000 would fall in that statistic. In Romania, I found 27 mothers died during that period of time in over 100,000 births. I just wanted to compare that to other countries. The US and Romania have some room to improve. Sweden, Japan, these are just kind of hit or miss countries around the world. Czech Republic, Singapore, all have really low maternal mortality rates. Now we could talk, and we're not going to spend a lot of time right now on this, but we could go into all kinds of investigation and thought process, brainstorming about why we have these rates in our countries and across the world, and I know you can come up with some ideas. Let me just throw out one. Why do you think the US and Romania have higher rates of maternal mortality than some of these other countries that are listed, Sweden, Japan, Singapore? Any ideas? Just one right now and we'll go on. Maria? Yeah, the U.S. has maybe births at their home, in the home, and having less hospital deliveries and more births and all that, maybe. You know, I think from our perspective, from nutrition, the individuals may not be getting the nutrition they need during pregnancy, and then that doesn't give them the ability to handle that pregnancy, which is a very traumatic thing. So that's just some reasons that we could throw out, and we could, that's one of those things that could be a whole conference looking at that information. I wanted to also show infant mortality rates. And this is U.S. infant mortality rates. This is, again, per 1,000 live births. In 2000, we were 6.8. Now we're about 6.0. And we're ranked, the U.S. is ranked 33rd in the world right now, that was the 2007 statistics. Romania, and this is something else we could do a lot of investigation on. In 2000, it was about almost 20 deaths per 1,000 live births. Between 2009 and 2010, something happened. Went from 23 to 11, and I don't know. Anybody have any ideas? It could be the way statistics were gathered. It could be that there was some big health promotion program. I don't know, but that's the statistics that were available. Why such an improvement? Again, that could take a long time to investigate and come up with some reasons. I just also wanted to show how that our two countries, 6 and 11, rated with the rest of the world. Singapore has kind of been the #1 country in the world for quite a while. They only have 2 deaths per 1,000 live births. And we look down the second, third, Czech Republic's 10th. The U.S. is about 33rd. I didn't see a ranking for Romania, but it'd be less than 33rd. So we all have ways to improve our infant mortality rates, the outcome of pregnancy. We could improve maternal mortality, we could improve infant mortality, and support those pregnancies better. And that's one of our goals, one of the things we try to do. Now, thinking about those two things, those maternal mortality and infant mortality, let's just kind of brainstorm now, what are some risk factors that happen during pregnancy that put that mother at risk and also put that infant at risk? What are some things that would cause that person, that mother, to not survive the pregnancy? What would happen during pregnancy that would cause that baby to either not survive the pregnancy or not survive the first year of life? What are some things that you can think of? What are some situations? Premature birth. If that baby's born too early, they aren't in the womb long enough, they don't have the infrastructure needed. And let's just think about this. My mother told me I was born. I don't remember the process. I mean, maybe some of you remember that process, but you're coming through that really small opening, and you can just imagine what's going on there. That's a pretty traumatic situation. That baby going from a water bath, spa setting, nice warm environment, and then all of a sudden they're thrust out into this environment, probably really bright lights, people talking, lots of noise. That's a big adjustment just from the standpoint of all the senses that child's now feeling. But what are some of the other things that child also has to make the transition from the womb to the world? What are some of the other body processes that have to happen when that child's in the womb, then they're transitioning to the world? What are some of the transitions that baby has to make? Breathing, yeah, they have to breathe. Instead of getting their oxygen through the umbilical cord and gas exchange happening at that level, now you have to have a functional respiratory system. That's huge. If your baby is born too early, that last month of life, last month of development is very instrumental in making that respiratory system functional. So that's one thing, the respiratory system, the ability to exchange oxygen. What else? Digestive system. Instead of having that nutrition pumped in on a daily basis, the waste products pumped out, now that baby has to be consuming food, breast milk hopefully, and that baby's consuming breast milk, but they still have to digest it and absorb it. That digestive system isn't functional, that baby's in a world of hurt. So that transition from the womb to the world is Not going to happen. And we could go through all the different systems. All those systems have to happen. Urogenital system, all that sort of thing. What are some things that could happen during pregnancy? Disease states, other types of things that would potentially affect that pregnancy, the outcome of the mother during pregnancy and the baby. Infection, exposure to different disease-causing bacteria, that sort of thing. It's possible. Okay, we could look at specific nutrients like folic acid. We know folic acid is very important for development. You know, if you don't have enough folic acid, what's the side effect? Neurological, spina bifida, neurotube defects, all those sorts of things. Yeah, you could have maybe an ectopic pregnancy. The attachment start detaching the placenta, start having problems with the actual movement of nutrition and waste products from the baby to the mother. Other things. Medications, if the mother happens to be taking medication that can cross the placenta and cause damage, that could be it. Genetic diseases, if the baby has something that, and even mother has PKU, phenylketonuria, and doesn't control phenylalanine in their diet, that phenylalanine can cross into the high levels of phenylalanine can cross into the baby. What else? Diabetes. What do we call that diabetes in the mother if it happens during pregnancy? Gestational diabetes. And just luckily, that's the one I was going to be talking about. So we're going to be talking about gestational diabetes a little bit. We could go on again. That's something we could talk about forever, the different causes of maternal and infant mortality or problems with survival. Now, during pregnancy, we have some hormones that are elevated, including human placental lactogen and human growth hormone. These are both insulin antagonists. They cause insulin to be, or the mother to be resistant to insulin. So the mother has to produce more insulin to have the same effect. Now what that does is it tends to cause the mother's blood glucose to elevate. Now to a certain extent that's good. And just thinking about how nutrients cross the placenta, glucose crosses as in a facilitated diffusion from an area of large concentration to an area of lesser concentration. So the mother's concentration of glucose has to be higher than the baby's. The baby uses glucose very quickly because it's an energy source, and all that fast growing uses that glucose up pretty quickly. But if you don't have a little bit of a concentration gradient from a high concentration level to a lower concentration level, you're not going to get that glucose to flow across from the mother to the baby. That's good to a certain extent, but when it gets too high, then it causes potential problems with outcomes of pregnancy. It can cause problems with the mother, also cause problems with the fetus. Largely what happens is that baby gets too big. We call it macrosomia. The baby gets a lot of glucose flowing towards, because it has that passive diffusion flowing into the baby, and that baby uses that for an energy source first, but then it starts storing that glucose. What do we store glucose as usually? There's two different things we can store glucose as. Remember? Glycogen is one. Do we have unlimited glycogen stores? No, we don't. We have some liver storage and we have some storage in cells. What happens if we have all of our glycogen stores filled? Yeah, we convert it into triglycerides, don't we, into fats, into actually fat molecules. So that baby starts storing that glucose as fat. So that baby gets big, and we get that macrosomic baby. Why is that a problem? Here you have my wife gave birth to two 10-pound babies, and she, was in agony. It's not a real pleasant thing to have a huge baby trying to fit through that small opening. And you can cause damage. And it's not only uncomfortable, you can cause damage to the baby and to the mother. So you have, just physically the potential problem with having a large baby. But gestational diabetes mellitus does increase the risk of maternal problems, maternal death or damage and neonatal risk. Now, Jesse and I think several different people, including Karen just in the last presentation, talked about evidence-based nutrition practice. And I think if one thing you'll come away from this conference is we're a very science-based profession, and we're going to be using that science in a way to help our public. But one of the things that we have been talking about from the Academy standpoint, from Academy of Nutrition and Dietetics, is we have an evidence analysis library, and this analysis that's been done has produced evidence-based nutrition practice guidelines in lots of different areas. And there are guidelines for gestational diabetes. Now I put this up again where the EAL can be found. Now this is a member benefit if you're a member of the Academy, but you might want to all take advantage of, we have a 1-week free subscription for anybody to go in and use it. So if you want to go in and look at it, just kind of choose that 7-day period, you can go into this place on the website. It's still, I think it's at ADA and also AND, Evidence Library. You can find that. But also, you have your iPhone, and I think it's also available for other smartphones. You can go in and buy what's called NutriGuides, and I have that up there. It's available, you go to iTunes, and it's only $2.99, which is about, what, 10 RON or so, somewhere in that neighborhood. And I have it on my iPhone, so I can go in and just press it up. There's an app for everything. And you can utilize this for your access to certain information, including gestational diabetes. But I'd suggest you go look at that if you have a chance and use that 1-week free subscription. But the evidence-based analysis library has lots of different things available. We've already kind of talked about these, so I won't go into a lot of detail right now. But the one about gestational diabetes, basically we train analysts to analyze pieces of literature, and we come up with 2 conclusions. And when Jessie was talking about kidney disease, she was talking about the strength of the evidence and the importance of that certain practice. So the strength of the evidence is either strong, fair, weak, consensus, or insufficient data. And also the importance is whether it's imperative, it has to happen, or whether it's conditional depending on the situation. Now I'm going to just talk about a few of these, but first I want to give a definition of gestational diabetes from the American Diabetes Association, and they say that it's any degree of glucose intolerance with onset or first recognition during pregnancy, which means that a person could be a type 1 diabetic or a type 2 diabetic and then enter pregnancy with that diabetes. They wouldn't be considered gestational diabetic. But if a person is diagnosed with diabetes during pregnancy, they're gestational diabetic. Now there could be circumstances, and I've had a client, at least one client that I've dealt with, that actually was diagnosed with diabetes during pregnancy, and she had type 1 diabetes. She just happened to have, at that point, the onset of that type of diabetes. So she had type 1 diabetes the rest of her life. But true gestational diabetes is diagnosed during pregnancy, and it usually goes away after pregnancy. But the person at high risk for gestational diabetes is somebody who has marked obesity, they may have had a history of gestational in a previous pregnancy, they have glycosuria, which means they have glucose in their urine, or they also could have a family history or a previous birth to a large baby. One of the things when my son was born at 10 pounds, the doctor at that point asked, do you have a family history of diabetes? Because 10 pounds is a large baby. Diagnosis, I just wanted to really quickly go over this. There's 2 ways to diagnose diabetes, at least in the United States, and I think it's probably pretty similar here. There's a 2-step method where you do a fasting plasma glucose, which is over 126 milligrams per deciliter, or a casual plasma glucose, which means they don't have to be fasting, it's over 200 milligrams per deciliter. And then you repeat that on the next day and get the same result. So that's a 2-step method. It takes 2 days. Or you can do a 1-step method, which is an oral glucose tolerance test. You give that person a oral glucose load, then you check their diabetes or their blood glucose over the next couple of days. Impaired glucose tolerance has kind of several different definitions, but It just means that that person's blood glucose is elevated. It's not necessarily up to 126 yet at a fasting level. Now, this is where we're starting to get into some of the guidelines. And one of the, whoops, I've gone up over my 20 minutes, my duck went off. So I'll just go over this real quickly. The gestational diabetes, one of the points that has really good documentation is that all pregnant women should be assessed for the risk of gestational diabetes at their first prenatal visit. When they're first time they go to the doctor after they find out they're pregnant, then they should be assessed. If they know before that, it's a good idea. Their doctor's working with them and they go to the doctor and they know that they have, the doctor and the patient know that they have potential problems with diabetes, they should know that then, and they should be assessed right away. Depending on the risk, then the timing of the check should happen, or the screening. This is strong evidence. There's lots of evidence out there that says this is important to do, and it's imperative to help with reducing the risk of problems with the mother and the baby. Most women are screened between 24 and 28 weeks of gestation. That's when that seems to kick in. And again, this is strong and imperative. Then once that person is diagnosed with diabetes, then the registered dietitian should initiate the visits with that woman within a week, and there should be at least 3 visits. And again, this is strong and imperative, strong evidence for this, and imperative this needs to happen, because if that woman doesn't receive that, she could have problems with her own survival during pregnancy, and it's going to put her neonate at risk. So that needs to happen early, and needs to happen within that time frame. And again, a minimum of 3 visits, that's a minimum. It may require more than that. I'm going to just give a real brief case study here and let you think about it for a moment. I'll give you the highlights, and then I'm going to ask you one more question before I sit down. Here's a 34-year-old woman who's in her 2nd pregnancy. She's already had 1 baby that was born healthy and is alive and well today. She's 162 centimeters. Her pre-pregnancy weight was 180 pounds, or 81.8 kilograms. I did the BMI for you. It's about 30. What do we know about a 30 BMI? Anybody know what that puts her at? It's obese. It's right at the obese, overweight threshold. So she would be considered overweight or obese. So far, she's gained 22 pounds in that first 24 weeks. What's that? Is that probably too much? Because she probably only needs at that maybe 15, 20 pound, maybe 25 pound weight gain. If you were very well monitoring, she could probably get away with that. But 22 pounds in the first two trimesters is probably a little too much. And then she has, the patient reports, her family history reveals that her mother has type 2 diabetes. Now I'm just going to ask you this one or two questions here, kind of in reverse direction. What more information do you need about this woman before you could start doing much effective counseling with her? What she eat? What's her lifestyle? One of the things that I tend to say right up front with any person is, do you have a place to live? Do you have what's your support structure? Do you have a house? Do you have a refrigerator? Do you have running water? All those just physiological needs. That needs to be answered first. If she's out there a homeless person, it doesn't matter what you're going to tell her, she's not going to probably be able to do what you ask her to do or what you work out. So physiologically, does she have the physiological needs met? Then we start talking about food, that sort of thing. Family history. Occupation, what's she do? Is she employed? How many hours does she work if she is? What does she do? Other things you need to know. Family status. Does she have a husband, support structure? Does she, we know she has one other child. Does she have a mother who can help her with supporting things? Does she have brothers and sisters that can be helpful, friends that can be helpful? You know, you need to know what kind of support structure she has. What other data do you need before you can start giving a whole lot of advice? Yeah, so the information about the previous child. Okay, now let's say you're getting some information now. At 24 weeks, based on what I said already, should she have had some sort of or some sort of test or screening for diabetes? She's overweight. She's got a family history. That puts her at high risk. So she should have already had a screening. We don't know if she has. So that's another question you need to ask, if she has already been screened for gestational diabetes. If not, she's at 24 weeks. Based on information, if she hasn't been screened, what do we know needs to happen now? She needs to be screened. We need to do one of those two tests to see if she has gestational diabetes, whether it's a two-step or a one-step, to see what her insulin tolerance is, or her glucose tolerance. So I think that's going to be kind of it, but just to, kind of think about from the perspective of a person like this who comes in, you're talking to her, you need to find a lot of information about, but number one, is her physiological needs met? Do we need to find a place for her to live first before we can deal with other things? So thank you, and I think I went over my time. I had my duck timer up here and we went off. So our next presenter, we go into our next one now, and who is it, Daniel, do you know? Gigi. Gigi's up. There you go.